Anaesthetist, Dr. Christos Apostolidis, currently working in cardiac anesthesia both in MITERA and EDAIC hospital, and he's going to talk to us about post-cardiac bypass inflammatory syndrome. Looking forward to your talk, Christos.
Thank you very much for this opportunity to speak in this session. My topic will be post-cardiac bypass inflammatory syndrome, which is essentially a form of systemic inflammatory response syndrome gone the wrong. It's inflammation actually gone the wrong way. There's an off-balance response to bypass, and inflammation goes down to the offense. It complicates adult cardiac surgery and also up to 1/3 of children undergoing cardiac surgery. As far as the pediatrics are concerned, there are specific Sears criteria, which are age specific. But the problem is that Sears in children is mostly underdiagnosed. There is a lack of consensus on neonates because neonates lack the ability to maintain their temperature and exhibit a huge variability in their leukocyte count. The specificity is quite high, but sensitivity of these criteria isn't. There are various etiologies. Many of them involve the bypass process, namely the material of the circuit, the oxygenator itself, the reuse of shed blood, which is very important, and we'll see that afterwards, the use of blood and blood products, and the management of lungs during the bypass. The activation of the acute phase reaction during the bypass is an extremely complex process. It occurs at different times, has a big extent and time-wise, and has various triggers. The surgical trauma itself, blood contact with the non-physiological surfaces of the extracorporeal circuit, endodoxemia, and of course, ischemia. There are several mediators that are involved, and they exert synergistic effects and amplify the process. Leukocytes and endothelial cells play a key role in the events following bypass. There are two phases of generation of Sears during bypass. In the early phase, there are 5 cellular and 5 humoral components, and in the late phase, we have the entities of ischemia and reperfusion and endotoxemia. Bypass circuitry lacks the endothelial surface, and plasma proteins are rapidly adsorbed on the circuit, and they form a monolayer. They undergo conformational changes that expose receptors to circulating proteins and cells. This leads to the activation of these two groups, humoral and cellular groups, which are responsible for coagulopathy, tissue edema, organ dysfunction, and multiple emboli. Now, here we can see that the intrinsic coagulation system gets activated when blood is in contact with the non-endothelial circuit surface. And as soon as the surgical trauma starts, we have tissues, non-vascular tissues that come in contact with factor 7. So tissue factor and factor 7 form a complex which directly activates factor 10. Also, this tissue factor and factor 7 complex is formed also during the bypass, independently on the trauma. What I would like to stress here is that thrombin is formed. Either way, thrombin is formed, no matter if we use heparin or not. So thrombin possesses inflammatory properties. It causes microemboli and microthrombi. And what is very, very important is that tissue factor is found in the pericardial cavity. Complement activation is mostly via the alternate pathway, but also with the classic pathway, the antigen-antibody-dependent pathway. And well-known antigen-antibody complex circulating is protamine heparin after the trial to reverse heparin action. The net effect is anaphylactoid reactions, increased capillary permeability, bronchoconstriction, hypotension, cellular activation, and so on. Now, fibrinolysis works in parallel to the coagulation system, and it takes place also in the pericardial cavity. Plasminogen is incorporated in the fibrin strands, and tissue plasminogen activator takes its place. So plasmin is activated, and it cleaves fibrin into fibrin strands and fibrin split products. This is important when shed blood is taken into the oxygenator. Now, the cytokine storm, it's again an immunological reaction. It's an immunological reaction that is off balance again. It's on the offense. There are various inflammatory and pro-inflammatory cytokines, which are more pronounced than the anti-inflammatory cytokines, such as IL-10 and IL-8. Every cell can, in certain conditions, participate actively to this inflammatory response by producing or releasing substances or messengers, reactive oxygen species, gene expression, and so on. Now, as the aortic cross clamp is lifted, ischemic tissues, namely heart and lung, become reperfused. So there is an intense inflammatory reaction with all the before aforementioned results. Endodoxemia during bypass has long been recognized. Endotoxin is the most potent activator of innate immunity and inflammatory response. It originates from the microbes in the gut, and it takes place regardless of the use of perioperative chemoprophylaxis. We're not talking about here about bacteremia, but we're talking about endotoxinemia. Possible mechanism could be splanchnic vasoconstriction resulting in ischemia. Also, it could be due to the non-pulsatile nature of the blood flow. Now, proposed risk factors for Sears in pediatric cardiac surgery could be age or type of lesion, weight, duration of bypass, and bypass specifics, or the use of blood products. The logical thing to say would be that a low birth weight child has a greater bypass surface to body surface area ratio. Therefore, it could exhibit a greater degree of inflammatory reaction. This holds true for infants and older children, but it hasn't been proven in neonates. Neonates have an underdeveloped immune system, so they don't seem to be reacting in this way. In this study, although younger infants did exhibit an increased inflammatory mediator production, its clinical manifestation and significance was modest. In this one, concerning, again, pediatric cardiac surgery, the authors conclude that there is a reduced inflammatory response to endodoxemia in neonates during bypass as compared to adults, and thereby explaining the possible increased susceptibility to infection afterwards in the ICU. Now, as far as the type of lesion is concerned, there seems to be an upregulation of pro-inflammatory cytokine genes in children with cardiac defects, especially those with volume overload. Furthermore, hypoxia, such as in patients with tetralogy of Fallot, may suppress the expression of anti-inflammatory cytokines, such as IL-10. TNF-A levels are elevated in patients with tetralogy of Fallot undergoing intracardiac repair. It's also suggested in this study that we could use TNFA levels to predict inflammatory reaction after the bypass. Now, there is an extensive research and effort and debate to minimize the contact of patients' blood to the bypass circuits by using miniaturized circuits, oxygenators with filters, lowering the priming volume, or using autologous priming, blood priming. The results are modest, and this is further complicated by a lack of standardized process. Now, the use of blood or blood products is implicated to the trial clinical entity, irrespective of whether the patient is on bypass or not. In the pediatric cardiac setting, fresh frozen plasma seems to be independently implicated in Sears. Nevertheless, priming with less volume or use of autologous blood would seem like a logical thing to do. Now, what are strategies that we could use to mitigate the inflammatory response? Of course, the early use of heparin in an attempt to make use of its anti-inflammatory properties and to halt the coagulation process, which, as we said, is not feasible because it acts at the thrombin level. But it seems like a logical thing to do. We cannot separate ourselves from heparin and bypass. Now, corticosteroids are a field of enormous debate. We always talk about corticosteroids in cardiac surgery. Now, in this meta-analysis of 56 randomized controlled trials, steroids had an unclear impact on mortality and actually seemed to increase myocardial injury and incidence of new onset atrial fibrillation postoperatively. Now, in the pediatric population, there is again uncertainty of whether we should or should not routinely use steroids. The inflammatory markers may be reduced, but they're just biomarkers. Now there is this trial, the stress trial, that's on right now until the next June, and this will test the net effect of methylprednisolone given in 2 doses, one 8 to 12 hours before the surgery and one in the bypass. Now, there are several other suggestions, such as the routine use of phosphodiesterase inhibitors, and in particular milrinone, or the development of antioxidants. What we could do in the CBB-wise, of course, these are logical things. Reduce the bypass duration, reduce the bypass surface area, use encoded with heparin or poly-2-methylethyl-acrylate tubing, and of course, processing the shed blood. As I said, fibrinolysis and thrombin generation is happening in the shed blood of the pericardial cavity. So we should be using filters or even a cell saver to process this blood. Continuous ultrafiltration removes excess water from the tissues, and modified ultrafiltration after the separation from bypass removes excess water from the lungs. And they're useful in improving oxygen extraction and also cytokine removal. Now, there is one other technique, which is a novel technique. It has been tested in patients under coronary artery bypass. And this is the Durandus Technique, in which the patient's lungs are used as an oxygenator. So there's no ischemia in the lungs. So we have lower inflammation, as we can see in lower levels of IL-6 and IL-8. And there is a less blood loss in the ICU. So the take-home messages from this talk would be that bypass causes inflammation, which is a complex process and involves cellular and humoral systems. It may cause considerable morbidity, mortality, and increased length of stay. There are several measures we suggest, but they're from now nowadays they're of limited value. We haven't had any conclusive results yet, but there is ongoing investigation, and neonates exhibit less of an inflammatory response than previously thought. Thank you very much.
Thank you, Dr. Apostolidis, for an excellent presentation for such an interesting and difficult topic.